showing some videos, but hitting some important points in the management of hydrocephalus and third ventriculostomy. Actually, when I'm interested in subject, I want to go directly to the results, then go into pathologies and anatomy and things like this. So when I saw the results of endoscopic third ventriculostomy, it was ranging from 50 to 75%, and it's somehow disappointing for some surgeons that you're doing a procedure and you have a failure rate. And the failure of this procedure has its own causes. Things are in the operating theater and things pre-operative and things post-operative, and how to manage these problems. Actually, the heading here is the liqueous membrane as a cause of failure of endoscopic third ventriculostomy. Most of neurosurgeons are familiar with the liqueous membrane as hitting the liqueous membrane, going through the craniopharyngiomas and going the retrochiasmatic approaches, the subfrontal approaches, and things like this. The anatomy of the liqueous membrane, it's arachnoid condensation, as you can see here, and it's confirmed of three parts: the diencephalic part here, and the mesencephalic part, and the suprasellar part here. These are the three parts of the liqueous membrane. Actually, the suprasellar part, that this is the part we are dealing in endoscopic third ventriculostomy. As you see here, a sagittal section of the midbrain and the dorsum silli and the infundibular recess here. We go from the third ventricle down to the floor of the third ventricle, hitting the floor and dilating it. There is still another membrane here, may cause some failures in endoscopic third ventriculostomy. Analyzing my failure in 200 patients of obstructive hydrocephalus, and these are selective patients of aqueduct stenosis, and 10 years follow-up. 25% of them of total failure. 23% was early failure, and 2% were late. Late failure, 4 patients over 10 years, and the earliest was after 3 months. The latest was after 6 years and underwent a redo ETV. How dangerous this failure is? Actually, the death of reported in failure of ETV are 4 occasions since 1990 till now. So the death is quite low in endoscopic third ventriculostomy failures. The fear is that you have obstructed hydrocephalus and you manage your patient and let him go away, and he has no shunt and he's obstructed, and some people told them that he's already did the surgery and it's safe to go like that. These deaths were reported, and there was acute rise of ICP. 3 of them were children with closed head, and 1 of them was an adult. In early failures, 23% from 3 days to 3 weeks. This does not include the transient CSF leakage or wound flap collections or transient fontanelle elevation. Patients below 1 year of age were not included in this study. All were operated with the same endoscope and the same technique. Early failures, 2 groups. The early failure, whether a redo group, a non-redo group. A non-redo group, they underwent shunting. So these failures, before 3 months after operations, some of them went to redo ETV and other for a non-redo or a shunt. Early redo ETV, 47%, 21 patients. All of them had post-operative CT scan, MRI after defining this failure. 14 patients found to have open floor, but with intact Lillquist membrane. 57, and this is a very big number. These are 66% of the failures. And 57% were children above 1 year, 42% were adults. Showing you this video of aqueduct patient. Here is the infundibular recess, the pulsating. This is the redo third ventriculostomy. Here is the opening of third ventriculostomy after 3 weeks. We're going to, here is the mammillary bodies, the basilar artery here, and the CSF pulsation over the floor of the third ventricle. Dilating the floor to maximize the opening. Dilating the floor to maximize the opening to see what's the cause of this obstruction. Here is the Lillquist membrane, as you see it here, a second membrane at the floor, which causes the obstruction or the failure of this endoscopic treatment. Here's another trial for dilatation of, we'll go right and left to dilate the floor. With balloon dilatation, slowly inflating the balloon and going out. And we look over, and here is the obstructive, there is the obstructing Lillquist membrane. Here's the basilar artery, here's the basilar artery, and here is the Lillquist membrane over here, which causing the obstruction. The aim here is to open this second membrane, as this is the cause of failure. We're going to dilate it also with a balloon. Here's a balloon dilatation of the Lillquist membrane, of the second membrane. And the balloon is tucking, and here's the opened Lillquist membrane and the basilar artery at the bottom of your field. This is a working third ventriculostomy. Beforehand, it was not. As you see here, here's the Lillquist membrane open after the opening of third ventriculostomy, and this is the floor of the third ventricle, and here is the Lillquist membrane, the suprasellar part and the diencephalic part. We operated here. This is the suprasellar part we operated. After defining failure of third ventriculostomy, you have fluid collection, subgaleal collections, and symptoms and signs of increased intracranial pressure. You may wait, but some studies said that you have to wait for 3 weeks and do lumbar punctures and things like this. Actually, my opinion is you have to wait just for 1 week. Other than this, you put your patient into complications. After 1 week, do CT scan for your patient, and there is either a collection or subdural collection or no subdural collection. If there is no subdural collection, so there is no CSF passed through this ventriculostomy and go up over the subdural space. So you had a failed endoscopic third ventriculostomy. You have either to do a shunt, to put a shunt, or to redo this surgery again. If you do have a subdural collection, so there is a defect in the absorption. You have a successful third ventriculostomy, but there is a defective absorption. So do a lumbar puncture and leave him for 2 or 3 weeks, and it may succeed. If not, then put a shunt. But from the start, if you have failure, don't leave it till 3 weeks and then you take an action. After 1 week, do a CT scan. Either you have a subdural collection or no subdural collection. Thank you. Some videos of endoscopic procedures like craniopharyngiomas, and one of the interesting subjects are the craniopharyngiomas inside the third ventricle, and this is a third ventricular craniopharyngioma after opening the wall inside the foramen of Monroe. If we came here, here's the choroid plexus and here's the foramen of Monroe, and this is the wall of the craniopharyngioma. A lot of cortical crystals and calcifications. This is inside the craniopharyngioma. Here's the floor of the third ventricle. Actually, opening the craniopharyngioma inside the lateral ventricle, this is not the end of the story. You have to make a double opening. Opening in the lateral ventricle and the other one in the cisternal part. You have to do another one in the cisternal part. Here's the opening of the cisternal part, dilatation of the floor of the craniopharyngioma and the third ventricular floor. You have many difficulties here. Identification of the floor, which is the safe area to go through. The best is following the rule, everything blue, you can hit it. Everything blue, you can hit. Anything red or something like this, you cannot hit it. Dilating this opening, here is the thickened cisterns or the arachnoid thickening at the floor. This patient had many attacks of chemical meningitis. Actually, this patient had a shunt thereafter, because these attacks of chemical meningitis blocks the floor, and this patient had a shunt afterwards. Follow-up of this patient for 6 years and no recurrence of this collection of craniopharyngioma. And no additive, no add-on therapy. We didn't give him any radiotherapy or chemotherapy or anything like this.